Hello, ladies and gentlemen. Hello, everyone. Our public health education program about consultant medical oncology series, new subject, cancers of the head and neck. Cancers of the head and neck. Introduction. Cancer of the head and neck is a relatively uncommon disease, representing less than 5% of all cancers in the United States and responsible for 21,500 cancer deaths in 1998. Head and neck cancer ranks as the 6th most common cancer worldwide, defining it as a major healthcare problem. The term head and neck cancer encompasses a wide spectrum of diseases with varied histology and site of origin, as well as diverse biologic behavior. However, more than 90% of these tumors are squamous cell carcinoma arising from the mucosa of the upper aerodigestive tract, oral cavity, oropharynx, hypopharynx, and larynx. The risk factor most implicated for the development of the head and neck cancer are tobacco and alcohol use. Alcohol potentiates tobacco-related carcinogenesis and is an independent risk factor. There is strong epidemiologic association between smokeless tobacco and oral carcinogenesis. Despite the well-publicized risk factor and concentrated effort to educate the public on the negative health risks associated with these behaviors, squamous cell carcinoma continues to be a growing problem. In fact, a large portion of the population at risk fails to obtain early diagnosis, and as such many present with advanced stage disease. Occupational risk factors for the development of head and neck cancer have also been identified and include nickel refining, woodworking, and exposure to textile fibers. Previous radiation exposure has also been implicated as a risk factor. Carotenoid contained in yellow to deep red colored vegetables may provide a protective role in that there is an inverse relationship between the consumption of fruits and vegetables and the incidence of head and neck cancer. Thus, dietary habits also play a role in the etiology of squamous cell carcinoma. There is an increased evidence that viruses contribute to the development of head and neck cancer. DNA from papillomavirus has been detected in malignant tissue from the head and neck. Furthermore, Epstein-Barr virus is closely associated with nasopharyngeal cancer, a cancer that is rare in the United States but is more common in Asian and North African countries. Genetic predisposition to head and neck cancer is suggested by its sporadic occurrence in young adults and in non-user of tobacco and alcohol. Mutations induce chromosomal fragility in an independent risk factor itself and correlates with the prospective development of second primary tumors. In this chapter, we discuss cancer of the head and neck arising in the upper aerodigestive tract, thus including tumor of the nasopharynx, oral cavity, oropharynx, larynx, and hypopharynx, tumors of the salivary glands which are divided into major and minor glands, are also presented. The role and recommended approach for neck dissection is also discussed. In addition, the roles for radiotherapy and chemotherapy as adjuvant or neoadjuvant treatment modalities are presented. Tumors of oral cavity, pharynx and larynx. The oral cavity. The oral cavity is the most common site of cancer in the head and neck. As with other head and neck tumor, oral cavity tumors are predominantly squamous cell carcinoma that are usually related to tobacco and alcohol exposure. It is estimated that oral cavity cancer will account for 30,200 new cases and 7,800 cancer-related deaths in the United States in 2000. The disease is the most prevalent in the 5th and 6th decade of life. The most common site with the oral cavity are the tongue and floor of mouth sites that account for over half of all tumors in these regions. Within these sites, over 90% of tumors are squamous cell carcinomas with a preponderance occurring in males. Tumors can also arise in other sites throughout the oral cavity, including the lips, upper or lower, gingiva, buccal mucosa, retromolar trigone, and hard palate. Backside of the soft palate. While the majority of tumors in these sites are also squamous cell carcinomas, other tumor histologies can be seen that often reflect that makeup of the mucosa and soft tissue in that region. For example, minor salivary gland tumors. Tumors are commonly found on the hard palate, which has the greatest density of minor salivary glands in the upper aerodigestive tract. In addition, unique practices found in some parts of the world may alter the distribution of squamous cell carcinomas in the sites throughout the oral cavity. For example, chewing tobacco or betel nut increases the proportion of tumors seen in the buccal mucosa and retromolar trigone. The following section highlights the clinical presentation and management of tumors of the oral cavity. This is limited primarily to squamous cell carcinoma of the oral cavity and most often the tongue and floor of the mouth. Clinical aspects. The tongue and related structures of the oral cavity serve a vital function in both mastication and articulation. When these structures are involved with tumor, their respective functions are impaired. Hence, patients with oral cavity tumors will often present with complaints of difficulty eating and speaking. The most common signs and symptoms in the patient with oral tongue lesions are localized pain, 45%, and the presence of an ulcer, 50%. Patients also may present with an asymptomatic lesion that they or their dentist has noticed. Often these are seen when patients brush their teeth or inspect their oral cavity. Because of the early symptoms and the relative accessibility for examination, over half patients with oral cancer will present with early stage disease. 65% of patients present with stage 1 or 2 disease. Several aspects of the physical examination are critical to the accurate assessment of oral cavity tumors. The first is the relationship of tumor to the mandible. Initially, this can often be assessed during the history, since most patients with mandibular involvement experience pain and difficulty with mastication. On physical examination, the proximity of the lesion to the mandible and the mobility of the tumor over the mandible should be noted. Palpation of the lesion, including bimanual palpation when the lesion extends to the floor of mouth or elsewhere, is also a critical part of the examination of the oral cavity. The clinical appearance of the lesions can often suggest the histologic diagnosis. The most important aspect of clinical appearance is whether it is mucosal or submucosal lesion. The vast majority of squamous cell carcinomas are mucosal. In contrast, submucosal masses may result from a vast array of histologies, including minor salivary gland tumors and soft tissue tumors. Several ominous signs can be seen in patients presenting with the advanced oral cavity tumor. The first is trismus, which suggested that the pterygoid temporalis and masseter muscle are involved. The second ominous sign in reduced tongue mobility, which suggests involvement of the deep musculature of the tongue or the hypoglossal nerve. Finally, if the tumors display a deeply infiltrative pattern of growth rather than an exphytic pattern, survival usually is poor. Patients with squamous cell carcinoma of the upper aerodigestive tract have a high rate of both synchronous and metachronous multiple primary cancers. For this reason, any patient found to have a squamous cell carcinoma of the oral cavity should have a complete head and neck examination. Likewise, a high index of suspicion in the warranted in a patient with a history of previous squamous cell carcinoma of the upper aerodigestive tract who has complaints originating in the oral cavity or upper aerodigestive tract. Radiologic evaluation should be performed in a patient with an oral cavity tumor that is the close proximity to a bust or is fixed to the mandible. The initial and most simple test is the panoramic X-ray. This film provides information regarding the entire mandible but is limited in its ability to evaluate the symphysis and lingual cortex. If a lesion is close to these areas, the panorex may be supplemented with dental occlusal films and intraoral dental X-rays. Computer tomography scanning of the mandible can be used in the selected cases where the panorex and dental films are inadequate. A cross-section representation of the entire mandible may be seen using the software package DentaScan, which reconstructs the computer tomography image. Yes, different films and figures show us panoramic X-ray of mandible showing bone destruction, invasion of inferior alveolar canal, and so on. And different computer tomography, the mandible. Cervical lymph nodes in oral cancer, the risk of occult metastasis is relatively high for most primary tumor in the oral cavity. For this reason, all but the earliest lesions should have elective treatment of the neck in the form of external beam radiation or supraomohyoid neck dissection. The risk of occult metastasis from an oral tongue or floor or mouth lesion is directly related to the thickness of the primary tumor and increased significantly in lesion greater than 2 mm thick. This information can be used preoperatively to determine which patients have the highest risk of harboring occult neck disease and may benefit from elective neck dissection. Continue so many details. Nasopharynx. Although malignancy of the nasopharynx are comprised predominantly of tumors arising from the epithelium, as with other sites in the upper aerodigestive tract, they have several unique characteristics. This includes their clinical presentation, histologic subtypes, treatment response, and surgical treatment. This defining characteristic of nasopharyngeal carcinoma are presented in this section. Radiographic evaluation, staging, so on. Clinical presentation. Nasopharyngeal carcinoma arises most commonly from the fossa of Rosenmüller, which is located along the posterolateral wall of the nasopharynx, just above the orifice of the Eustachian tube. Eustachian tube tumor growth is the region leads to symptom of the sensation of air fullness, unilateral series otitis media, conductive hearing loss, othalgia, nasal obstructive hyposmia, and epistaxis. With more advanced disease, cranial nerve deficits may develop and are found in 15% to 20% of patient presentation. Cranial nerves 5 and 6 are most commonly involved. However, the most common symptoms experienced by the patient with nasopharyngeal carcinoma is the neck mass. This highlights both the difficulty in diagnosis these indolent tumors as well as the propensity for early lymph node metastasis. In a series of over 5,000 patients with nasopharyngeal carcinoma, regional lymph nodes involvement was found in over 90% of patients at presentation. And so on continue. Yes, the larynx and hypopharynx. Larynx, the larynx and hypopharynx, as with other sites in the head and neck, over 90% of larynx and hypopharynx cancer are squamous cell carcinomas. The larynx is the second most common site within the head and neck, and it is estimated the larynx cancer will account for 10,100 new cases and 3,900 cancer-related deaths in the United States in 2000. General consideration and some details. Clinical presentation. The majority of patients presenting with cancer of the larynx and hypopharynx have a history of prolonged tobacco and alcohol use. Males outnumber females, and the majority of patients present in their 6th and 7th decade. The most common presenting symptom for patients with tumors of the larynx is change in voice. The vibrator characteristic of the epithelium of the vocal fold is disrupted early in the process of the tumor invasion in patients with cancer of the glottic larynx. In addition, patients are very sensitive to changes in or loss of their voice. For these reasons, most patients with vocal cord cancer patients with early stage disease, in contrast, symptoms related to supraglottic larynx and hypopharyngeal primaries such as dysphagia, odynophagia, and othalgia tend to occur late in the disease process. With this insidious tumor growth, a high percentage of patients present with advanced stage disease. Evet, yes, hypopharynx. Salivary gland tumors. Salivary gland tumors. Historically, tumors of the salivary glands have been treated with surgery alone. The importance of adjuvant radiotherapy in the management of salivary tumors has become evident over the last decade. Surgeons, assuming the responsibility of the patients with salivary gland tumor should possess complete understanding of the varied pathologies and growth characteristics of these tumors, planning an appropriate procedure that encompasses the primary tumor and the potential routes of metastasis requires a maintained knowledge of the complex anatomy. Tumors of the major salivary glands include those arising in the parotid and submandibular glands, although the majority of diseases are glandular in origin. The proximity of tissue arising from all pre-embryonic layers enables the potential for both salivary and non-salivary tumors to be present in the salivary gland. The parotid gland. Early in the first fetal trimester, the parotid gland arises from the epithelial lining of the oral cavity. The epithelial cord develops appendage, recannulates and becomes hollow structure as it is intimately associated with branch from the facial nerve. So many details continue. Radiologic evaluation, chirurgical approach, and so many figures. Adjuvant therapy, radiation therapy, and so on. Submandibular gland neoplasm. Submandibular gland neoplasm. In the majority of patients, the finding of mass in the submandibular gland is due to ductal obstruction from calculi. Submandibular gland tumors account for 10% to 15% of all salivary gland malignancies. Malignant submandibular tumors occur in a reported 38% to 50% of previously untreated patients. Such a tumor in the submandibular gland has twice the likelihood of being malignant and as compared to the parotid gland. Different chirurgical operation, neck dissection for cancer and head and neck. Chirurgical management and cervical lymph node metastasis, neck dissection. And that's all this subject, and another subject. Chirurgical oncology medical site. Medical oncology site, consultant medical oncology public health education program. Neoplasm of the lung, new subject. Neoplasms of the lung. Yes. Primary lung cancers. In the United States, lung cancer is the leading cause of cancer death in both men and women. The American Cancer Society projects the lung cancer incidence to be 164,100 new cases for the year 2000, with a male to female ratio 1.2/1. Despite our best effort, the overall 5-year survival rate has remained low and is again estimated for this year to be less than 10%. Approximately 85% of all lung cancer occurring in cigarette smokers, despite the concerned effort curtail smoking by establishing smoke-free environments in public transportation, department stores, hospitals, and restaurants. And despite preventing cigarette advertising on radio and television, more than 50 million Americans smoke. The United States remains the leading exporter to tobacco in the world. Extensive lobbying by tobacco companies from states whose economy and viability depend on the tobacco industry continues to undermine efforts to curtail cigarette smoking. With few exceptions, prognosis in lung cancer is influenced by the stage of the disease at presentation and by the treatment that can be rendered. Curative treatment requires earlier detection and effective control of the primary tumor before metastasis occur. Chirurgical treatment of lung cancer is still regarded as the most effective method of cure, provided a complete resection is possible and the risks of the procedure are low. It is the therapy of choice for early stage non-small cell lung cancer. Lung cancer, as classified by World Health Organization, encompass non-small cell cancers that include squamous cell carcinomas, adenocarcinomas, large cell carcinomas, and small cell lung cancers. In North America, adenocarcinoma is currently the most frequent histologic type and makes up nearly 1/2 of all cases. Squamous cell carcinomas account for 1/3, and large cell carcinoma about 15%. In the rest of the world, squamous cell carcinoma continues to be the most prevalent. It is now standard practice to carefully stage all lung cancer at the time of the initial presentation. The American Joint Committee for Cancer (TNM) staging system has been used since 1972 and the international staging system since 1986. Both were revised in 1997. Briefly stated, tumors confined to lung without any metastasis, regional or distant, are classified as stage 1. All other localized tumors are classified as stage 2 or 3 disease, and tumors presenting with distant metastasis are classified as stage 4 tumor. More than 90% of lung tumors can be diagnosed and staged accurately without thoracotomy by one or more of the following procedures: percutaneous fine needle aspiration, bronchoscopy, mediastinoscopy, or mediastinotomy, thoracoscopy, and biopsy of accessible metastases, for instance, cervical lymph nodes. This approach has become particularly important when preoperative therapy is under consideration. Histologic documentation of mediastinal lymph node involvement will currently prompt serious consideration for combined modality treatment failing pre-treatment diagnosis and staging of patients. An exploratory thoracotomy is advised. This occurs in less than 10% of patients. The use of positron emission tomography, PET, this professional positron emission tomography, not so many every hospital, very seldom. Scanning in the diagnosis and staging currently being investigated. Surgical treatment is generally offered to all patients with stage 1 or 2 disease and to specific groups of patients with stage 2 disease. In discussing therapy, we will refer to our own experience, which is consistent with other reports in the literature, and will indicate those areas that the controversy still exists. Occult carcinomas. Very few patients with lung cancer are diagnosed before the cancer becomes apparent on chest röntgenogram, accounting for less than 1% of lung cancer population. In this occult group, diagnosis usually established on sputum cytology or by bronchoscopy in patients presenting with unexplained cause or hemoptysis and normal chest röntgenogram. Then different stage, superior. Treatment, different stages. Less common primary tumors. Less common tumors of bronchial origin include benign tumors and low-grade malignant neoplasm that arise from the epithelium, ducts, and glands of the tracheobronchial tree, and account for approximately 0.5% to 1% of all bronchopulmonary tumors. Included in this group are carcinoid tumors, adenoid cystic carcinomas, and mucoepidermoid tumors. Benign tumors, less than 1% of lung tumors are benign. They are derived from all cell types and may be parenchymal or endobronchial in location. The most common benign tumor is the hamartoma. This name was first used to denote abnormalities of the liver and bile ducts, and by definition represents an overgrowth of normal tissue that serves no useful purpose. It is most commonly an overgrowth of cartilage and is pathological designated as a chondroma or a chondromyxoid hamartoma. Arrigoni and Associates reported that hamartomas make up 77% of all benign tumors of lungs. Other benign tumors, carcinoid tumors. Carcinoid tumors, bronchial carcinoid constitute less than 1% of all lung tumors. Most tumors are confined to the lung or bronchus, but 10% to 15% of patients have regional lymph node metastases at diagnosis. The smoking history is rare. Although bronchial carcinoid can occur at any age, typical carcinoid usually occur at a younger age than primary lung cancer, median 42 years versus 62 years. Rarely do patients with typical carcinoid present older than 55 years of age. Clinical features. The symptom and physical finding depend on the location of the tumor. The peripheral tumors are most often asymptomatic, presenting as solitary pulmonary nodules on röntgenographic studies of the chest. Those presenting endobronchially are usually symptomatic cough, hemoptysis, and recurrent bouts of infection are common symptoms. Because of the small size and slow growth of these tumors, symptoms may persist for many years before the underlying cause is discovered. A history of wheezing or recurrent infection dating back many years is common. These tumors frequently masquerade clinically as bronchial asthma, chronic bronchitis, or bronchiectasis, particularly if the tumor produces the incomplete obstruction and is located in the trachea or proximal portions of the bronchial tree. Stridor can be the presenting symptom in the tracheal or main stem bronchial tumors. Recurrent hemoptysis results from the ulceration of the hyperemic mucosa overlying the tumor or simply from chronic inflammation distally. This is the most commonly seen in the carcinoid tumors, and in women has been noted to be accentuated during times of menstrual flow. The carcinoid syndrome occurs infrequently and almost exclusively in the patient with hepatic metastasis. Fine needle aspiration biopsy of peripheral lesions can be accurate by histologic examination of tumor tissue is the only completely reliable means of diagnosis. None of the radiologic techniques accurately differentiate these tumors from other benign and malignant neoplasm. Computer tomography scans are helpful in the staging bronchial carcinoid, but mediastinoscopy is not essential once a carcinoid diagnosis is established. Fewer than 15% of cases have nodal involvement. More importantly, even if lymph node metastases exist, their presence does not preclude surgical treatment because long-term survival is still possible. In our experience, with 23 surgically treated patients with nodal involvement, 75% were alive at 5 years, and local control was effective in 22 of 23 patients. Diagnosis, treatment, adenocystic carcinoma, clinical features, the malignant tumor also called cylindroma. Cylindroma is a slowly growing malignant lesion arising from bronchial mucus glands and is similar in most respects to adenoid cystic carcinoma of the major and minor salivary glands. It is much less common, 1/10 as common than carcinoid tumors, much more aggressive and has a poorer prognosis. As with carcinoid tumors, there is an equal sex incidence and similar age range. The commonest incidence occurs in the 5th decade of life. Mucoepidermoid carcinomas. These carcinomas are extremely rare bronchial tumors. They are seen most commonly in persons in the 5th decade of life, but have been reported in patients as young as 10 and as old as 75 years of age. Sex incidence is approximately equal. Primary sarcomas and lymphomas of lung. Primary malignant tumors of non-epithelial origin are rare, representing less than 1% of primary pulmonary malignancies. In this group are included tumors that arise from mesenchymal structures or sarcomas, and tumors that arise from the reticuloendothelial system or lymphomas. Sarcomas. It is estimated that the sarcomas occur in lung in the 0.2% to 0.0113% of cases. Sarcomas generally arises from the stromal elements of the bronchial wall or lung parenchyma. Rarely do they invade and break through the bronchial epithelium. As a result, these tumors don't exfoliate, and diagnosis by cytologic examination of bronchial secretion is unlikely. Then continue. Lymphomas, malignant lymphomas arising lung make up 0.34% to 0.45% of all lymphomas. The lymphomas in the lung is considered of primary origin only when it meets the following criteria as described by Saltzine and Lehost. Metastatic cancer to lung. Pulmonary metastases are very common with advanced cancers. nearly 1/3 of all patients dying of cancer have pulmonary metastases. More importantly, 15% to 25% of metastases are confined to the lung and frequently to one lung. And continue. Detailed so many. Clinical presentation. Since most pulmonary metastases are peripheral, most patients have no symptoms at the time of the diagnosis of their metastases. Symptoms usually result from delay in diagnosis or generally reflect endobronchial disease, pleural involvement or compromise of the lung by the large bulky tumor or by extensive multiplicity of the metastases. Routine bronchoscopy is generally unrewarding. In the presence of multiple lesions, preoperative biopsy usually is not necessary. In the instance of the solitary lesion, differential diagnosis necessarily includes benign lesion of the lung and a new primary lung tumor. Hence, tissue diagnosis becomes essential. In general, a solitary lung lesion is more likely to the metastatic if the primary tumor is a sarcoma or a melanoma. It is more likely to a new lesion if the novum primary tumor is of head and neck, lung or breast origin. In patients with cancer at the other side, there is an equal chance for a solitary lesion to be new lung cancer or a benign lesion as opposed to a metastasis. Atkins and associates reported on 50 patients presenting with a solitary lung nodules following treatment of malignancy elsewhere in the body. The mass was benign in 9 patients, a new primary lung carcinoma in 9, and the metastasis in 32. In 1984, Casey reported that 3% of 1,416 patients with breast cancer had presented with solitary pulmonary nodule, synchronous or metachronous, and half of these were primary cancer, 5% were benign, and the rest were metastases from breast carcinoma. Yes, pre-treatment workup, treatment, the role of adjuvant therapy, other considerations, surgical approaches, comments and conclusions. Shortly, maybe should be expression. Comments and conclusions from 1965 to the present, over 400 reports have addressed the results of surgical treatment of pulmonary metastases from variety of primary tumors and tumor sites. Except for germ cell tumors, the expectation of overall 5-year survival rate in patients with most tumors following treatment of pulmonary metastases in less than 50%, despite treatment by surgery, chemotherapy, or both, until sustained responses to systemic treatment become uniformly possible by novel treatment regimens. Pulmonary metastectomy, metastasectomy will remain an essential consideration in the treatment. The advent of thoracoscopy has refocused our attention on the impact of complete resection for lung metastasis. Some advocates of thoracoscopy believe that complete resection of multiple metastases is a myth, and the concern about missing very small lesions that are not seen on computer tomography scans or visualized on the thoracoscopy but are palpable at the thoracotomy does not necessarily imply greater likelihood of prolonged survival in those patients with lesions that might be missed by thoracoscopy. The problem will necessarily resolve itself if effective systemic treatment becomes available for those tumors currently non-responsive or partially responsive to chemotherapy. And continue. But this subject, that's all. And another subject related, our lungs covered outside mediastinum and pleura together, different regional and composed and dense area. Neoplasms of the mediastinum. Neoplasms of the mediastinum. Historical aspects. The neoplasm found in the mediastinum are the diverse group of tumors which include thymic lesions, lymphomas, germ cell tumors, neurogenic tumors, endocrine tumors, and other rare tumors. Successful chirurgical treatment of mediastinal tumors required the introduction of endotracheal anesthesia and close pleural drainage. Prior to these developments, mediastinal surgery was limited to attempts involving lesion in the anterior mediastinum. Complications such as pneumothorax often proved fatal. The history of mediastinal tumor is rarely one of the individual neoplasm. No notable landmarks are listed. Recently, advances have been made in the surgical treatment and the medical management of the diverse group of tumors confined in the borders of the mediastinum. Multimodality treatment has significantly improved survival in many of these neoplasms. Improvement in diagnostic techniques has decreased the need for unnecessary surgical procedures. Newer, less invasive surgical techniques have decreased the morbidity of surgery in many cases. This chapter will focus on the neoplasms seen primarily in the mediastinum, excluding those found in the mediastinum as metastases from other sites or by direct extension. This chapter also will not include the cystic lesion that represent 25% of mediastinal masses in many series. Yes, incidence. Mediastinal tumor most frequently present in the third or fifth decades of life. Azarov and colleagues compared primarily mediastinal tumors in adults and children. In the pediatric population, the most frequent tumors were neurogenic, 47%, thymic, 28%, lymphoma, 9%, and germ cell, 9%. In the adult population, thymic neoplasms were the most frequent, 31%, followed by lymphoma, 26%, neurogenic tumors, 15%, and germ cell tumors, 15%. Davis et al. Looked at 2,399 patients across multiple studies combining pediatric and adult populations and found an overall incidence of mediastinal neoplasm as seen in table 10.4. The distribution of tumors in the various compartments for adults and children is seen in table 10.5. The incidence of malignancy varies with age as greater than 20 years old. Approximately 43% of tumors are malignant. Grossfeld reported a series of 201 children with mediastinal tumors and reported 73% of these were malignant and 27% were benign. This compares to an earlier study by the same authors where 76% were malignant and 24% benign. From the Duke series across all age groups, malignant tumors constitute 42% of mediastinal neoplasm and cysts. According to this study, masses in the antero-superior mediastinum are more likely to be malignant, 59%, than those found in the middle mediastinum, 29%, or posterior mediastinum, 16%. Symptoms and signs. Symptoms and signs. The symptoms and signs found in patients with mediastinal tumors depends on a number of factors, including the patient's age, the malignant status of the tumor, the tumor's locations and size, and associated systemic or paraneoplastic syndromes associated with the tumor. A 56-year experience at Duke University Medical Center found 62% of patients, adult and children, presented with symptoms from mediastinal neoplasm or cysts. Malignant tumors had a significantly higher incidence symptoms, 85% compared to benign with large mediastinal masses. Schamberger and colleagues prospectively evaluated 31 children with anterior mediastinal masses and recommended using the tracheal area as assessed by computer tomography imaging and peak expiratory flow rate as measures to assess safety of general anesthesia. General anesthesia was uneventful in the study in patients with tracheal area and peak expiratory respiratory flow rates greater than 50% of predicted. Typically, symptom can be explained by the location and size of the neoplasm. For example, facial fullness and plethora related to superior vena cava obstruction. In an anterosuperior mediastinal mass, cardiac tamponade may occasionally be seen with middle mediastinal masses. Posterior mediastinal masses with spinal cord involvement may present with symptoms of spinal cord compression. Table showing the most common presenting symptom of the mediastinal neoplasm. Elevated. Yes, chest pain, fevers and chills, dyspnea, cough, weight loss, myasthenia gravis, superior vena cava obstruction, fatigue, dysphagia. These are common symptoms at the presentation of the mediastinal neoplasm. Okay. Elevated level of various hormones and serum markers are seen in patients with various mediastinal tumors. For example, in young male with anterior mediastinal masses, alpha-fetoprotein and beta-human chorionic gonadotropin levels can provide additional evidence in cases of suspected non-seminomatous germ cell tumors. In fact, these tumor markers should be measured in all male patients under 50 years of age who present with a mediastinal neoplasm. Often, systemic symptoms arise from hormones secreted from primarily mediastinal neoplasm. For example, hypercalcemia from elevated hyperparathyroid hormone production that is seen in patients with mediastinal parathyroid adenomas. Children with posterior mediastinal masses suspicious for a neuroblastoma or ganglioneuroblastoma should be screened for excessive neuroepinephrine and ferritin production. Example of systemic syndrome arising from hormone releases from various mediastinal tumors include thoracotoxicosis, the Dosage-Potter syndrome, and Cushing syndrome. The Dosage-Potter syndrome describes the episodic hypoglycemic episodes seen in the patient with neurogenic tumors and large mesenchymal tumors. Systemic syndromes associated with mediastinal tumor and their hormones are described. Table 10.8. When a patient initially present with mediastinal mass, careful history and physical exam should be performed. Symptoms such as chest pain, dyspnea, fever, chills, night sweats, cough, fatigue, weight loss, myasthenia, and dyspnea should be noted. Additionally, signs on physical exams such as lymphadenopathy, facial fullnesses, and plethora and testicular masses should be carefully evaluated in cases of suspected myasthenia gravis. The neurologic examination can provide evidence with sign of proximal muscle weakness, ptosis, and diplopia. When these neurologic signs are present, confirmation of myasthenia gravis. Myasthenia gravis can be obtained from measuring levels of circulating antibodies to acetylcholine receptors. The tensilon test or electromyelogram. Tensilon test or electromyelogram. Diagnostic radiologic evaluation and some different figures. Chest area, radiographic showing. Tissue obtaining technique. These are very detailed for specialists. Thymic neoplasm. Thymic neoplasm are a diverse group of lesions and have undergone multiple classification schemas as detailed by Shimosato and Mukai. These tumors were initially classified in 1916 by Ewing and later in 1961 by Bernards. The latter classification was widely used until 1976 when classifications by Rosai and Levine, followed by Wick et al. And Lewis et al. Were instituted. More recently, Snower et al., Suster and Rosai, Marino and Müller, Hermelling and Shimosato and Mukai have proposed classification schemas of thymic tumors and so on. Thymolipoma are rare tumor comprising 2% to 9% of thymic tumors. Usually they are asymptomatic and therefore grow to large size before being detected. They occur equally in men and women and usually are seen in patients in the 20 to 30-year-old age range. Thymolipomas are radiolucent masses. Computer tomography scanning, ultrasound, MRI imaging showing fat density in the correct location suggests in diagnosis and association between these tumors are various paraneoplastic syndromes has been reported, including Graves' disease, Hodgkin lymphoma, chronic lymphoid leukemia, aplastic anemia, hypogammaglobulinemia, and myasthenia gravis. Mature fat and thymic tissue are seen on histologic examination. Hamartomatous lesions, rare ectopic hamartomatous thymomas are usually found in the supraclavicular or suprasternal regions, occurs in the adulthood, usually in males, and are often present for significant time prior to presentation. Surgical resection efficiently removes the ectopic tissue without recurrence of disease. Thymic epithelial neoplasms. Based on histologic appearance and biology, thymic epithelial neoplasm are divided into three general categories: benign thymomas, malign thymomas, and thymic carcinoma. Thymomas most commonly occur in adulthood between the age of 40 and 60, and the male-female ratio is equal in patients with myasthenia gravis However, female patients predominate patients with myasthenia gravis, also present with thymoma at an earlier age than those without myasthenia. Thymomas were the most common mediastinal tumor seen in the Duke series, representing 17% of mediastinal masses. By far the most common location of thymoma is the anterior mediastinum, but ectopic locations have been reported. Symptoms from thymomas are variable. These tumors may be asymptomatic, or signs of symptoms may be present from local systemic autoimmune phenomena accompanying these tumors. Then continue different details. Show us some chest radiography patient and computer tomography. That's different subject about these rare tumors. Neurogenic tumors. Neurogenic tumors are the most common tumor found in the posterior mediastinum. Most of these tumors are found in the paravertebral location along the sympathetic chain or associated with spinal or intercostal nerve. However, less commonly, they can be associated with vagus or phrenic nerves. Rarely, these tumors are found in the middle. Mediastinum is associated with the great vessels, the pericardium or heart. And continue. So many figures that show us how to flashing outside the identity of doctors and histopathologic view. Ganglioneuroblastoma, another. So many, but passing most of them. Ganglioneuroblastoma. These neurogenic tumors are intermediate in malignant potential between benign ganglioneuromas and the highly malignant neuroblastoma. They tend to be seen in slightly younger age group than ganglioneuromas. Patients are usually symptomatic or presentation. They are composed of immature and mature ganglion cells. Histologically, two types are seen: composite, consisting of predominantly mature ganglion cells with focal areas of immature ganglion cells, and diffuse, consisting of mixture of neuroblasts. So many and very rich X-ray, computer tomography, MRI, and different clinical important figures. Teratomatous lesions. Teratomatous lesions. Teratomas are the most commonly found primary mediastinal germ cell tumors, making up approximately 70% of adult and 60% of childhood cases of mediastinal germ cell tumors in the literature. In contrast to previous studies, Moran et al. Reported 322 patients with mediastinal germ cell tumors and found only 44% of these were teratomatous lesions. And continue. Seminomas. At presentation, these malignant tumors are usually symptomatic owing to their size, presenting symptoms of cough, lethargy, weight loss, and SVC syndrome may be seen. Lymphoma, primary mediastinal lymphoma, defined as lymphoma isolated clinically and radiographically to the mediastinum, represent approximately 20% of mediastinal masses in adult and 50% in children. Over 90% of primary mediastinal lymphomas are Hodgkin disease, lymphoblastic lymphoma, or diffuse large cell non-Hodgkin lymphoma. And continue. Hodgkin lymphoma, non-Hodgkin lymphoma, lymphoblastic lymphoma, large cell lymphoma, so many. Endocrine tumors, parathyroid tumors. Mediastinal parathyroid tissue represent approximately 1% of mediastinal masses. Pre-divide 400 in the Duke series. In 80% or to 90% of patients, the mediastinal parathyroid tissue is an adenoma. Most of the rest of parathyroid hyperplasia, and less than 1% of parathyroid cancer. And continue. Thyroid tumors, detailed. Primary carcinoma. Primary mediastinal carcinoma. Primary mediastinal carcinoma is uncommon neoplasm occurring in 9% of series of 400 patients at Duke and 4.6% of collected series. Its origin is unknown, but differentiation from other poorly differentiated mediastinal tumor and extrathoracic neoplasm metastatic to the mediastinum is important due to substantial differences in the optimal treatment. Mesenchymal tumor, soft tissue tumor, tumor of blood vessel and lymphatic origin. So many subjects. Chondroma. Chondroma, these are rare, aggressive tumors that are derived from the primitive notochord. They are located in the posterior mediastinum and present with symptoms from compression of vital structures such as cough, dyspnea, chest pain, and spinal cord. These tumors occur more commonly in men, usually at age 40 to 60 years. The only valuable treatment is wide surgical resection, and long-term results are poorly because distant metastatic disease is common. Yes, that's all this program. And next program will be continue carcinoma of the esophagus. Carcinoma of the esophagus. Thank you very much. Thank you so much. You are patient. See you later. Love from us to the all of the world, citizens, countries. Thank you so much. See you later.